So our next speaker is Claudia Kawas, University of California Irvine, Cognitive and Brain Resilience, the 90-plus study.
So I definitely want to thank the organizers of this meeting, because I think it's really been a great day and I've learned a lot. And but the other thing I should say is that a number of years ago I started thinking, I said that the one definition at least of expert was a person who was willing to talk about something they knew nothing about. So the organizers of this meeting officially made me an expert today. And I have never published a paper that has the word resilience, reserve, compensation. I've learned how to spell those words, but as you will see, I'm very challenged by the definition of them. But everything that I'm going to show you is hot off the press. And really, Maria Carrata should be up here because she's the one who did all the analyses and made all the slides and tried to put some kind of precision to my fuzzy notions. So she's in the audience, and I thank her as always. So, first I'm going to talk a little bit briefly about the 90-plus and the operational definition of resilience that we used, the prevalence. I'm also going to be able to show you some lifestyle factors from 25 years before we define these people as resilient, and some pathology. And I promise you there are going to be no conclusions, but maybe plenty of questions. Just a brief reminder, the 90-plus study actually had its origins in the Leisure World cohort study. And in the 1980s, a 14-page lifestyle questionnaire was sent to every single person who lived in this retirement community called Leisure World, now called Laguna Woods. And that provides a lot of lifestyle information that I'm going to show you in a minute with regards to resilience. So in 2003, we said if you were alive and you were over the age of 90, we wanted you in our study. And we've done very, very well in terms of getting 83% of our sampling frame, which I truthfully think is astonishing. And although they all lived in Laguna Woods in 1981, we now go to 37 states to see them. So this was our way of getting around the fact that we wanted something closer to a population, not a volunteer study. We also wanted to get around the problems that you've heard kind of earlier about how your smarter people and the richer people tend to return for follow-up, and so we try to go to them. And to date, we've enrolled actually over 1,700 people, and I often say, whose stupid idea was this study? Because this has definitely been the hardest study I've ever been involved with. So first we had to define resilience, and after a lot of going back and forth, we decided in order to be called resilient, you had to at least have seen us for 2 visits, although you can see the range is from 2 to 26 visits. We've been following some of these people for a really long time. The visits are every 6 months, by the way. We said the average mini-mental had to be above 28 or above, and your last mini-mental had to be 28 or above, because we didn't want to catch people who might be starting to show some declines before death. And when we do that, this is what we find. So now we're talking about the top 13% of the cohort that we are following were deemed resilient. And for the future slides, you will see that the resilients are always going to be in green and the dementia is always going to be in red, and you can compare what we find. So here's a snapshot of them. You can see the mean age is actually 97. By definition, the mini-mentals are much worse for the demented, about 25 for the people we call not demented but also not resilient, and 29 for the resilient folks. And in the data that I'm going to show you about lifestyle, you can see that that data was collected actually almost more than a quarter of a century ago. So the first hypotheses I had, some of these didn't even seem like hypotheses to me, was education, ApoE2, and lifestyle might be related to resilience. So we take a look at that, and here you can see, in fact, there is a very nice dose relationship for the percentage of individuals who had any school beyond college, with the highest number being in the resilience on the right. I know some of these might not be, these are This is the graduate students in education. Not too much going on sex. And of course, we hypothesize that in terms of ApoE, most of us, if we have a choice, we would say we want to be a 2. We would say we don't want to be a 4. But it turns out, at least in this definition of resilient, it didn't matter. Demented individuals were more likely to have a 4. But you can see that in terms of 4, did not distinguish between resilient or not resilient. In fact, the resilients had more likely to be ApoE4, which I think is something very important, especially given the age of these participants. E2, in contrast, we expected would be more in the resilience, and in fact, the highest group that had an E2 was the dementia group. Go figure. Lifestyle. So here you can see a variety of lifestyle. Most of these results, by the way, are not significant, but in general, resilient people, now this is 30 years ago. 30 years ago, people who are now deemed resilient were sleeping more than their non-resilient colleagues or their demented. They were watching TV less than their non-resilient colleagues or their demented. There's a little bit of an attempt happening here with the exercise variable that we have. And there's also a dose here with the attitude. That is, the individuals who were in the top tertile for some attitude questions answered a quarter of a century ago were more likely 25 years later to be resilient. So maybe attitude does in fact matter. I hope so, except I got to improve mine. So the next set of hypotheses we had was that cognitive resilience is related, at least in part, to the absence of dementia pathologies. I mean, if I gave you a choice of having good cognition and having a head that's free of amyloid and vascular disease and Lewy bodies, or having good cognition and still having amyloid, I think most of you would choose to not have the pathology. So we assumed that resilient individuals would be more likely to have absent pathology of all sorts, and that non-demented individuals with AD pathology, because most of the time, most of the field defines them as preclinical AD, we would assume maybe they were having the subtle declines compared to their colleagues. So this is work from actually a number of years ago, and you can see that if you die in your head with a lot of amyloid in your head, as shown here, the high plaques, or if you die, these are non-demented individuals, at least when they started, or if you die with almost no plaques in your head, which are up here, your rate of decline is exactly the same, about 1 millimennel per year. Now, we all know that in an autopsy study, we only get one chance to look at whether or not there are plaques and tangles. It's at the end of life, and we don't know how long they've been there. But at least with this kind of follow-up, which, as you can see, is up to age 105 or 6 in some participants, it did not look to matter what your decline was before death based on whether or not you had high plaques or high tangles. Where the data looks exactly the same. How about the absence of AD pathology? So up here you'll see that 25% of these individuals in the 90-plus study come to autopsy and have 0 amyloid, which actually surprised me a lot. I mean, we think of amyloid and deposition as being so strongly age-related that I really didn't expect a full quarter of people in their 10th decade and beyond to not have amyloid. But when you look here, you can see that, yes, having no plaques essentially distinguishes the demented from the non-demented, but it doesn't distinguish the resilient from the non-resilient. Similarly, tangles distinguishes demented from non-demented, but no difference between those who are resilient and those who were non-resilient. And the percentage of intermediate or high AD pathology also distinguishes the demented, but once again does not do anything between the resilient and non-resilient groups. So this really actually surprised me. I mean, I really expected to have different pathologies in this group. And that was, I'll come back to that in a minute. We've spent the last 30 years or more separating dementia due to Alzheimer's disease from vascular factors. In the old days, we called it hardening of the arteries and all sorts of things. And I think that I feel like I'm on a diamond where I spent a lot of time taking dementia away from vascular disease, and it all became Alzheimer's. Sort of now we see it coming back together. And I think this is an important area, not just for understanding dementia, but probably understanding resilience. So when we took a look at the vascular disease in our participants, and this is autopsy data, you can see that one thing that did distinguish the resilience from the non-resilience and the dementia is the presence of large or lacunar infarcts. So resilients were much less likely to have either kind of infarct. They were also much less likely to have atherosclerosis, moderate or severe atherosclerosis. Now, this is a very crude measure for those of you who work with the NAC database. I'm not even sure what this means, but what I am sure of is that it's different in resilience compared to non-resilience. We did not find a similar difference with arteriosclerosis, however, and a little to my disappointment, in fact, the percentage who had one or more microinfarcts was highest in the resilient group, even beating out the demented or the non-resilients. But I think there might be a signal there in vascular disease. This is an abstract that was presented at the Society for Neurosciences, and I wanted to show it to you because, as you can see, Dr. Rogalski is an author, and Dr. Goela was the pathologist, and all the other people from Northwestern who are here and work on superagers. And what they wanted to see was what was going on in some of our best 90-year-olds. So Dr. Goela actually cherry-picked 8 cases out of almost 300. And he had all the scores, the cognitive scores longitudinally, all the memory scores, and he selected 8 individuals who had exceptional memory performance and also good performance on all of the other cognitive domains. So these are essentially our 8 best people to come to autopsy, and what he found was that we had everything. So at one end of the spectrum was a couple of people who had only a little diffuse amyloid, no neuritic plaques at all, a tangle stage of 1, which is essentially where the 90-year-olds start. But at the other end of the spectrum, there were 2 people out of the 8 who met criteria for pathological Alzheimer's disease, and we had everything in between. So the entire spectrum of pathology was apparent in these 8 people with very superior performance, which to my mind only confuses. I'd hoped this was a result because we were just looking at 8 people, but the more I look at it, the more I think that I really believe that resilient people have the entire spectrum of pathology. These individuals, by the way, were all between 95 and 100. So the last thing I'm going to show you has to do with cognitive resilience in the presence of AD pathology, and I was very much hoping that it would be related to ApoE genotype and to education. And in fact, here you'll see that our E4s are almost always demented, not 100%. And by the way, we have even an E44 among the resilient, in answer to one of the last questions. The E2s, however, are much less likely to be demented. This is dementia now. But the pathology in the E2s matches the pathology, the AD pathology in the E4s. So while most of these people are demented, most of these people with the same level of pathology are not demented. And the pathology in the E2s, much to my surprise, was a higher level than the pathology of the E3s, shown in the center. So looking at autopsy is one thing. We wanted to look during life. We've recently completed doing about 130 amyloid PET scans and MRIs, and we're just starting to look at the data. When we look at individuals who are negative or positive, both of these are normal individuals, and we wanted to compare the cognition of the positive individuals to the negative ones, and no difference in cognitive performance between people who are positive or those who were negative. And then you put education in the mix, and here's what happens. So in individuals who are negative on their amyloid PET scan, those with a lower education level have essentially the same risk as negatives with a higher college degree or graduate school. But among the positive individuals, those with low education have a 4 times increase in their odds of having cognitive impairment. Most of these individuals, by the way, are not demented, so we're talking cognitive impairment now. I think the one thing that's really striking is how no matter who looks at what, education always pops out, and I think there's something important there, although I always worry it has to do with the tests we're giving and whether they're hard enough for the more highly educated individual and those kinds of things that were brought up earlier today. So final thoughts.
Okay.
Since I'm running out of time, it's really good. So we're all familiar and have seen today the Jack model, and from this grew the notion of preclinical Alzheimer's disease, and from that grew the notion of a lot of secondary prevention trials, like the A4 trial, which is now going on, to see if we can prevent dementia in a group with amyloid positivity. But I have to ask, after sitting here all day, are we really enriching this for preclinical disease, or are we doing these prevention trials in resilient individuals? Just a query. So to summarize.
Claudia, you're really over time.
Oh, there's a summary.
Thank you.
Just leave it out.
Great
Yeah.
talk. Okay.
So can I sit?
No, we have a few minutes for questions.
No.
It's a separate interval. Do you see? And
Now I see.
you're 1 minute over.
I am not resilient.
Yes, you are.
No.
Okay, questions. Go ahead. In the back, yeah.
Hi, it's Mary Ganguly. Claudia, you know we senior citizens need our afternoon naps, and I'm really glad I stayed awake long enough to hear your talk, for which I've been waiting all day.
Yeah, but those who sleep more are resilient.
That's right. That's right. I'm trying to preserve that. So I have a comment about this study, and it's also kind of a general comment that it's really great to be able to have these cohorts of really old people and to follow them for as long as possible. But we remember, but then we forget that not having followed them their entire lives, we don't really know what happened along the way. We do know that these are the survivors and that we are not studying the people who fell by the wayside, and we don't know what predicted these people still being among us. But we also don't have the opportunity to look at the risk factors or exposures and perhaps the windows within which they operate. So there may be a period during which education and occupation are the most helpful, and then it stops being helpful, or maybe it's not helpful up to a point and then only after that. Exposure to vascular risk factors, many of these windows of opportunity for intervention may already have closed by the time we recruit people into our studies at age 60 or age 90. And as you have shown, and we've also shown, many of these standard risk factors for dementia, for example, seem to operate up to age 80 or 85 or so, and then they stop having an effect. And ApoE, if we have ApoE4 and we haven't demented by age 80, around that age it stops increasing our risk. I mean,
Correct.
we could still dement, but it wouldn't be because of that. And I really haven't heard this point about timing of exposure being addressed in any of the talks we had today. But hearing about all these cohorts that have been followed since youth, I think this is, the best argument for following them all the way to the end of their lives, and for somebody supporting studies like that so that we can look at the whole range of exposures. Now, with just your cohort, with just the 90-plus cohort, you followed them for quite long.
We follow them until they die.
But I mean, you've managed to follow them for longer than most people can follow such people. So have you seen anything to do with timing even in this age group? Are there ages at which alcohol use is protective or smoking is protective? And
No, I think mostly what we've seen is that, as you pointed out, the risk factors that are identified in earlier late life, like hypertension and high cholesterol, actually appear to be protective in this age group. ApoE is definitely no longer operant as a risk factor for dementia, for incident dementia also. So all of the risk factors we've identified don't seem to work in this group, and we're kind of frantically trying to understand what is operating in this
So
group.
maybe it's
Okay.
alcohol and smoking after age 80 or something like that.
You have to give somebody else a chance. We only have time for one more question. Okay?
I think
Thank
she
you.
wants us to go get our resilience at the cocktail hour.
Yeah. One more question, and we'll wrap up here because it's been a long day.
I guess it's more. Is this on? I guess it's more of a statement than a question. I mean, I think these studies are fantastic. As an animal model person, you know, what we want out of these human studies is testable hypotheses that we can then go and do everything that was being described. And you know, mice, rats, primates, they do age in a way that is you know, shows hallmarks of human aging. They may not be perfect, but you're not going to do a 100-year-old study that involves 5,000 people and expect all to be sitting here saying the results in 100 years. I mean, we have to bring the human field closer to the animal model field, because we can do what you can't do, and you can't do what, and we can't do what you can do. So I think waiting for that perfect human study is never going to happen. Combining animal models with humans is the way to go.
Well, I can't wait to see what you'll do with the animal studies and inform us. Yeah.
Can I make a quick comment?
Please.
It takes less than 3 years to make a 90-plus rat.
Okay.
Yeah, when the rat people complain about how long a study takes, I always want to.
Well, you heard it here first. Okay. Thank you all for just a fantastic symposium. Thank you, Claudia.